Greetings. Let us learn about ERCP. What is ERCP? Endoscopic retrograde cholangiopancreatography. And this is used to evaluate the bile duct and the pancreatic duct. And the first step is to pass a duodenoscope into the second portion of the duodenum. Next is cannulation of the ampulla of water, followed by injection of contrast into the bile duct, that is cholangiography. Because we are injecting from below, it is retrograde cholangiography. Because we are injecting using an endoscope, it is endoscopic retrograde cholangiography. And if you inject into the pancreatic duct, that is pancreaticography. And because we are injecting from below, it is retrograde pancreaticography. And because we are using an endoscope, it is endoscopic retrograde pancreaticography. And that's basically involves injection of contrast. And how do you see the contrast injection? You have to use an X-ray or fluoroscopy to check the contrast going into the bile duct and the pancreatic duct. And unlike regular endoscopy, which is either EGD, colonoscopy, and enteroscopy, which is performed in a regular room, for ERCP, you need X-ray control to see the injection of dye under X-ray or fluoroscopy. So we do the procedure in the fluoroscopy room. As you can see, the team has to protect themselves from the radiation. They need to wear a special gown or the lead apron to prevent radiation exposure. Unlike the EGD and colonoscopy, where we put the patient in the left lateral position, for most ERCP procedures, patients are in a prone position. And as you can see here, the patient is in a prone position, and because ERCP is much more complex, most endoscopists prefer to do the procedure with general anesthesia and endotracheal intubation. So before we do the procedure, everybody should wear the protective gear to protect them from radiation. This involves wearing a lead apron and also use a lead-lined glasses that protect the eyes, as well as a thyroid shield to protect the thyroid. And on the chest, you see a monitor that monitors the amount of radiation exposure. This is the radiation badge. So as an assistant, before you get into the ERCP room, you should wear a lead apron, thyroid shield, place the radiation badge, and if possible, use special glasses. After the procedure, it's very important not to throw the lead apron on a chair or table, but one should hang it down so that the lead doesn't break inside that lead apron. If the lead lining breaks, you don't get any protection when you do the next ERCP. So make sure you take time and hang it to the wall like the assistant is doing there. When you go to the endoscopy room, you bring the duodenoscope. And the duodenoscope is like any other scope, but with two differences. One, it is side viewing, and number 2, it has an elevator that can move the instrument, either a catheter or a balloon or a sphincterotome, up or down. So let us look at how the duodenoscope looks different from a regular endoscope or an EGD scope or a colonoscope. Here is a duodenoscope. This is a side viewing scope, so you can see the lens and the light coming on the side rather than at the end. It has an elevator that is now in up position, and now it is in the down position. So let us look at how the elevator helps the endoscopist. Let us look at a side sectional view of the duodenoscope to look at how the elevator functions. There is a wire that moves the elevator from down to up, that allows the sphincterotome to look up, that allows the cannulation of the bile duct and the pancreatic duct. So we've learned about different aspects when it comes to Ercp. We do it in the fluoroscopy room. We use a duodenoscope, and let us go through the steps again. So here is a side viewing endoscope in the descending duodenum facing the ampulla, and with the help of the elevator you cannulate the bile duct, and with the wire you cannulate deep and inject dye and monitor the dye movement in the bile duct and the pancreatic duct using fluoroscopy. So we've learned about what it takes to do an ERCP, and let us learn about the role of ERCP in the management of diseases of the bile duct and the pancreatic duct. ERCP is used to manage bile duct stones. In the past, bile duct stones required surgery. For the last 30-40 years, ERCP has been used to remove the bile duct stones without the need for surgery. In addition, if the patient has a stricture and you want to find out if the stricture is from cancer or not, you can do a brushing and establish the diagnosis. Whether it is in the hilum or in the pancreas, you can actually diagnose cancer by brushing the stricture. In addition, these strictures can be opened up and allow the bile to drain into the duodenum by placing a stent. In other words, you could manage the stricture in addition to establishing the diagnosis. ERCP can also be used to fix leaks that happen, bile leaks that happen after surgery, especially after cholecystectomy, by placing a stent and allowing the bile to go down, and thus giving rest to that leak site, which heals on its own. So ERCP can be used for management of bile duct stones, diagnosis and management of bile duct strictures, and also management of bile leaks. Now let us look at the complications of ERCP. The most worried complication of ERCP is irritation to the pancreas, otherwise known as pancreatitis. And for the most part, pancreatitis resolves in a few days. Rarely it can be severe, it could be life-threatening. When you try to do an ERCP in somebody who has a stricture, they are at risk for infection, otherwise known as cholangitis. As the scope is going down the duodenum, sometimes if the anatomy is tricky, the scope could cause perforation of the duodenum. The scope during the opening of the bile duct with sphincterotomy, it could also result in perforation. Another complication is bleeding. We all should keep in mind that patients undergoing ERCP are typically taken care with sedation, so there is another concern of reaction to the medications. So these are all the complications of ERCP. For the most part, ERCP is very safe. What precautions should we take before doing an ERCP? So what are the precautions? And let us go through some checklists. We should check whether, if it's a woman in the childbearing age, we should check a pregnancy test. It's very important to do that. Exposure with radiation to a pregnant woman is bad news. We should also check whether the patient is allergic to either iodine dye or contrast. And if the history is there, they should be prepared. And these patients can be prepared with steroids, Benadryl, Pepsid, etc. Another risk is if you cut the sphincter, there's a risk of bleeding. So it's important to check the blood counts and the coagulation profile with PT and PTT. Also, in older patients and in anybody, it's also important to check if they have a pacemaker or a defibrillator, especially if you're planning to do any electrosurgery and cutting the sphincter. That is important to keep in mind. So let me review this. It's important to ensure pregnancy test is negative, as radiation is dangerous to the fetus. Check the drugs and contrast allergies. Allergies may require pre-treatment. And also make sure where the implants are, and if you're planning to do a cut of the sphincter with electrosurgery, you want to place the electrode pad away from that implant. I hope this is helpful. Thank you.